morning, good afternoon, everybody. I will pass this on to who was leading us today. Dr. Bitter, do you want to give us an opening welcome?
Of course. Hi, I'm Cindy Bitter, Associate Professor at St. Louis University and active in the SAM Wellness Committee, as well as initiatives at my own institution. We're here today to talk about moral injury, which is the latest evolution of some of the terminology that we're using to describe the stressors that we face as healthcare practitioners. We have a bit of a panel discussion today, so we'll go on to our group introductions and then actually try to sort of co-create some of our own definitions and meanings around this terminology as we figure out, as we progress through the slides and talk about ways to mitigate moral injury.
Thank you. Dr. Deutsch, do you want to start us off? Just quick introductions. It's okay.
Really still a newbie. Good afternoon. This is clearly a group effort today that you can see with a lot of strengths coming, that it's both medical students, residents, and faculty that are helping give this talk about what moral injury really is. So I wanted to thank everyone that is a part of this today. And you can see that we are a huge group that's going right now. And really, Dr. Cindy Bitter is leading this cause and helping us all do this. I'm Dr. Amanda Deutsch, if you don't know me already. We have Dr. Amy Kontrick here as well, Stephanie Baylant, Dr. Amanda Ritchie, Dr. Vitas Careless, and Dr. L.A. Alvarez. That'll be part of this group. And I will let Dr. Ritchie.
All right, guys. So as I was introduced, my name is Amanda Ritchie. So today we have a pretty good layout, different speakers, different perspectives. So we're going to, starting out with our introduction, I'll go through some ground rules that we want to keep in mind. We're going to define moral injury as it's, talked about in the literature, and then how we perceive it, give some examples, learn some individual strategies to address moral injury, and then define some organizational strategies that maybe we can bring to the places that we work. Conclusion takeaways, and then some Q&A. Now, with moral injury being such a sensitive topic, the next hour, we're going to be talking about some things that might be distressing, might be a little bit triggering. It can be stressful, and that's okay. If you need to take a break, take a breath, come back to the session after taking a moment for yourself. Totally understandable. It's being recorded. You can always come back and rewatch the section that you might have missed. So this is a topic, it's being brought forward as something that's critically important, not only to our professional lives, but our personal lives as well. And our understanding and ways of managing moral injury are evolving on a daily basis. And some things that work today might not work tomorrow as we learn more and grow more. And questions are welcome at the end of the session, but please remember that when you're phrasing your questions, that our words matter.
All right, I remembered to unmute this time. So really, when we're talking about moral injury, I think the interesting part of it, as someone that likes to think she's a wellness expert, is that moral injury is really this common term that's used in both burnout and wellness literature. But the meaning of it is not always easily understood. And I think sometimes I even have this hesitation when using the term moral injury, because that meaning can be a little bit unclear. So I think it's really important that we take time to go ahead and think about how we would describe moral injury. And so this is when we're going to ask that you get involved, because we think this will be the most interesting part. For instead of me telling you, I would really like to know, what do you think moral injury is and how would you describe it? So hopefully you can see the instructions here. I think the easiest way is potentially to text that number with SAM, moral injury. And please go ahead, it can be words, it can be a sentence, but we will take some time right now for everyone else to help us describe and define moral injury. I'm loving these already. Please keep them coming. These are amazing. They're going a little quickly for me to read them out loud, but it's really hitting on some themes here of doing what feels wrong, not delivering care as we know we could. Moral injury is a term used to describe the psychological, emotional, and spiritual harm that can result from participating in or witnessing acts that violate one's deeply held moral and ethical values. These are incredible. Thank you, everyone, for participating and sharing it. We're going to go on to the next slide. And best we could instead of doing best. Yes. With this definition of what we all just talked about, really wanted to understand, if you don't mind sharing and being vulnerable, really how it makes you feel when you witness or partake in one of these events, as someone said, that happen almost every day in the hospital, of what it makes you feel like, or what emotions come to mind when you think about what moral injury is. Thank you for sharing. I think this one, as it keeps even morphing and changing, we can kind of see how often all of us are feeling some of the similar things and how similar these words are of what it really brings about. And I think word clouds sometimes really have this ability to hit home of these feelings that are occurring. And hopefully someone that we get to capture this, because I think this is so important to have this piece and actually be able to see what this makes everyone feel like. So kind of made my job easy for me of what it is and what it's not. But I think it's just important, again, to clarify, because I think this group is obviously really capturing what moral injury is, but it's often a term that can sometimes, as I said before, be misused. It's not synonymous with burnout. It is not post-traumatic stress disorder, although there's some similarities that sometimes come about, which is why people think that. And it's not vicarious trauma or second victim syndrome. And so it does get used interchangeably with these concepts because it has been historically first started to be talked about after the Vietnam War, which is why PTSD and moral injury are spoken about similarly a lot of times. But it is defined as that feeling that a transgression has occurred, causing a reaction in some form of grief. And this crosses a line, as people had said before, that counters our beliefs, values, or ethical codes. And again, this doesn't have to be due to our own actions, but it can be a lack of someone else's. One of the main researchers in moral injury, Brett Litz, described it as perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. I think that's such a beautifully, simply put kind of little quote of how he describes it. The other thing I wanted to touch on briefly is that moral injury in healthcare is actually thought to be a little bit different and distinctly due to 5 different scenarios. The first, that our medical decisions lead to some form of adverse event. I'm not going to go into exact examples because I want to be able to discuss those later as we continue on. Second, that we do something that counters our values. The third, that we fail to do something in line with our values. The fourth, that we passively witness or learn of the failing to do something, or we did something that countered our values, those second two that we just talked about. And the fifth, that we experienced some sort of betrayal from someone we trust or the institution that we trust. And so it just teases that out a little bit differently. And lastly, if everyone can go ahead and answer this question of how often has anyone experienced moral injury in the past year, let alone 4 years? Well, I think it's pretty clear so far. There's no never as an answer. Thank you again for sharing, for being open, and we'll continue to move forward.
Hi, my name is Amy Kontrick, and what we'd like to do is take some time now to go over some examples of moral injury. And what we would like is hopefully for some folks to share what is the best way to identify someone who wants to share, have someone raise their hand and someone can take them off mute. Recognizing, of course, that as was mentioned in the previous slide, these instances may evoke feelings of betrayal, guilt, shame, fear, and anger. So if one doesn't feel comfortable sharing their own personal experience, we thought that maybe focusing on what has become more of a universal experience for all of us, issues around the COVID pandemic that you may have personally experienced, witnessed, or know others who have experienced. Would anyone like to share?
If you want me to break the ice, I can speak of a non-ER related analogy.
Go for it, Stephanie.
Sure. Thanks, Stephanie.
So I do animal rescue, and actually it was this past year we had a cat who was injured, and so someone called me, and so I went out and got the cat and brought it to the vet. And just like you sign for permission to release in humans, veterinarians won't treat the cat without permission to release. And if there's no one to be found, then ACO, animal control, will do that. But in this particular case, there was no one to be found. So I contacted ACO to get them to do the release. And then an owner was found. And so the owner believed in holistic medicine, not from a veterinary source, and refused to have the cat cared for. And you know, the police were involved, and we really tried everything, even buying the cat from these people so that we could get the care done, but they were adamant that they loved their cat and didn't want it treated by a veterinarian. And legally, I couldn't steal the cat. So I had to give the cat back to them.
Thank you, Stephanie. Mark, did you have something that you wanted to say? I see your hand is raised.
So, while working as an emergency physician, in the since the pandemic, with loss of staff, ancillary support staff, nursing staff, there's been a major difficulty in getting patients into the main treatment areas, with a lot of patients in the lobby, and even with initiating care from the triage point as a strategy. There are still people waiting sometimes 4, 5, 6, 7, 8 hours, which pre-pandemic, I had not seen that. I mean, I've been in emergency medicine over 30 years, and I mean, even I've worked in very, you know, challenged safety net settings, and this was almost unprecedented. And how it feels on the inside, almost being underutilized, knowing people are waiting for hours, some of whom are potentially in danger, although one tries to identify them through some sort of process out on the outer side. There's some near misses and actual misses that are painful, to one of whom involved a potassium, I don't know, 6.8 or something of that nature, that came back as a lab value. That couple hours went by, still with no room, an hour and a half, whatever it was, patient began to code. I mean, the patient was resuscitated. We knew it was a hyperkalemic code, but it wasn't, the patient wasn't in my zone, but didn't lessen the pain and upset and of that occurring. And I think working in emergency medicine right now, I've spoke to some of my colleagues, this is occurring around the country with very long waits, sort of on the outside, so to speak, while we're on the inside, feeling somewhere between helpless to, I don't know, it's quite upsetting. So I'm just throwing that out there. I don't know if other colleagues have had similar experience.
No, I think that's an important point, and it goes to the point where folks have mentioned that instead of being able to do everything or doing your best, it's the statement of we did the best we could, or we tried, and that feeling there. LA, did you have something that you wanted to say? Thank you, Mark.
Yeah, I wanted to follow up with that actually, because for me, it's the same thing. Now with the volumes kind of creeping up, or has been really high, and then now just adding more wait times. Even seeing patients in the waiting room, or even being told by consultants you can just discharge that patient, when 5 years ago, there's no way we would have done that. I think that it's not just the risk that we're taking on, which in and of itself can be traumatic. It's also that, like, we know that that's not really the right thing for that patient. Or sometimes if you know that there's 10 patients waiting for a CT scan, convincing ourselves that maybe we don't really need to do the CT scan, maybe we can convince the patient to just do something else. And in some ways, for me, that's the betrayal of what I wanted to do versus what I should do, and betraying myself because of the institution, because of what we're able to do, given the volume that we're seeing. So yeah, that's a very good point, Mark.
Thank you. Cindy, did you have a comment?
Yeah, so literally yesterday, we had a woman with a terrible asthma attack, came in, hypercarbic respiratory failure, put on BiPAP. She had had difficulty accessing primary care because of an insurance change, ran out of her controller, inhaler, ran out of her solution for her home neb machine, went through a couple of rescue inhalers and came in very close to being intubated, responded very well to BiPAP and stabilized. And we were planning to admit her, hopefully just overnight. She got so much better over the course of the next like 6 hours. And when faced with the concept of being transferred or sitting in the emergency department all night, she decided to leave. And we, we had some discussion around that and framed it as shared decision-making, that she was comfortable going home, but knowing it wasn't really the right thing or the safest thing to do for her. But the reality of it is that she was more comfortable going home, using her home machine and managing things at home, than she was sitting in an ER for the next 6 to 8 hours, hoping that she might get a bed or might be transferred.
Yeah, I think that's a situation that many of us have faced recently. Thank you, Cindy. Did you want to say something else?
Yeah, I just want to add to that, like it's interesting because we're able to isolate now in these discussions that it's that decision of a patient leaving, and we're kind of just coaching it as like maybe it's a shared decision making. But the reality is it's more than just that one instance. It's one after another, which is like that moral distress that just happens more than once. And then you get an angry patient screaming at you, and then you get like that later on that you missed this diagnosis, and then you get this letter about like Prasgeni or like your turnaround time. So cumulatively, I think for me that's why it's leading a lot more distress to clinicians, as opposed to that one thing that you may have kind of bend the rules a little bit to kind of be okay with sending somebody home that normally you wouldn't have done.
I think you're so right on that. And as we look to keep ourselves on time, I think that is a great way to end with two paraphrases of the great LA. One was, we are doing something that we would have never done before. I think most of us can relate to that statement since the beginning of COVID, whether it's protocols that we put in place to protect ourselves, to protect patients, to protect staff, watching patients die by themselves, having phone calls where family members have actually been told to go home and you're talking to them at home, limiting entrances into a room so that we could preserve PPE if there was areas where there was PPE shortages, ventilator shortages, all of those things that we did that we would have never done before. And then again, another great statement, I think, is that it's not just a one-off, it's one after another. I think that's a really important way to look at it. Thank you, everybody, for sharing.
So next, we're going to talk about individual strategies to help mitigate some moral injury. And the research on supporting evidence for individual strategies is pretty sparse, mostly due to the nature of this issue, and also a lot of suggestions that come from the military revolve around pastoral care. There's a lot of things that are really difficult to measure, and a lot of things that are going to be very independent to each person. So we did our best to kind of do a survey, and then there's also just some tips and tricks from us. And speaking about the military involvement here, I was curious what a combat veteran thinks. The concept of moral injury, as Dr. Judge pointed out before, was first investigated in the context of veterans. And the adoption of this term by stateside medical community has been debated. So I was curious to see what veterans were thinking about this. So this was a very convenient sample N of 1, and it is not representative of all veterans, but a colleague of mine, Corman Ligas, was a combat veteran and then also did work in the ER as a tech and is now pursuing his EM medical degree. So he provided me with this quote, and like completely unprompted, but he came up with this on his own just in response to my question, you know, what do you think about us using this term? And I thought it was interesting how it was so important to him that the people he worked with in the ER reminded him of his military friends, because to him, they were really dedicating their lives to helping others. And I think that was a nice to hear, again, just the perspective of one, but and then it was also important to him that we didn't use it colloquially, but we already talked about how, you know, what it is and what it isn't. So as long as we're using it appropriately, he said, I think it's a fair adaptation. I wasn't sure if anybody else with any military experience or military family members had any opinions on us adopting this terminology.
I mean, speaking for myself, I was Canadian Army medic. I think moral injury isn't just, you know, only related to one particular branch or service. I think in every service there are things that hurt an individual that go against their morals. And regardless of what you do in life, if it's against your principles, it's going to be a moral injury, regardless of whether you've signed on the dotted line to serve your country or not.
I like that. And then next, I'm just going to do a brief overview of some of the strategies that we found, including just some things that we do ourselves. So the first suggestion is participating in politics. And this can be a polarizing suggestion. So it's just, I wanted to keep it up there because without ED physician presence in political organizations, those involved in legislation won't get to know what you know, and they won't be privy to the perspective of what docs are facing every day. So, it can probably be really frustrating. I'm just starting out in the political realm, but it seems, like everything moves slowly, but ultimately, we do need to have a voice there. Does anybody have any opinions or thoughts on the politics participation suggestion?
Hey, I think you hit it right on, right? You have to be part of the conversation. If you're not part of the conversation, nobody is really going to advocate for us.
And then collaborating with administration. So this is something that was recommended in an article that we can send the link out to, but collaborating with administration means you have a voice with them. And honestly, one hospital at which I used to work as a nurse, we actually did have administrators round in the ED, and they would come and actually follow the docs and see patients with them just as a shadow. And they always provided feedback that even though they tried to prepare themselves on what to expect, they were always very surprised and overwhelmed. And there's books about leadership by walking around. But basically, if you can have the type of relationship with someone in the administration, so that they might be willing to, take a couple of minutes and see a few patients in the ED, then it might be more meaningful when people are making suggestions. And then one of the most important things is leaning into your community. Having a supportive and reliable team is one of the things that keeps us going back each day. And I don't speak for everyone, but I know that when the COVID situation was going on, I wasn't working as a doc, but when I was even thinking about not going in, that I would never not go in just because of my colleagues, just because that's kind of, no matter how bad things are, that your colleagues are there, so you're not going to not go in for them. So just leaning on your friends and your colleagues, and not just docs, but also just everyone in the department makes a team. So just knowing you can support them and knowing that you have their support is important. I hope that you guys get to feel some of that too. I know it's situational, depending on where you're working, but having a supportive and reliable team is important. So if you ever are in need of support, just don't be afraid to ask. And we have a whole campaign ongoing, Stop the Stigma. And we're really trying to make it more socially acceptable to ask for help, both from your colleagues and from professional resources, just because we all need support. And then also setting boundaries, kind of the opposite of that. Whereas, you might have a close-knit group in the hospital, you still need to have some boundaries when you're out of the hospital in order to not take the work home with you. So whether it's, including a little disclaimer in your emails that you're not going to be replying on weekends, or if you're just setting specific times of day where you're just not going to think about anything work related, it's going to be individual. But does anyone have any specific ways that they set boundaries?
I was just typing in the chat. Dr. Kanapiki Comer is a national expert on this. I'll find some of her blogs online, but there's a lot of work that she's done on setting boundaries for sure.
And so, like I said, there's not a ton of literature there, but thank you for listening.
Okay, so next we're going to talk about some organizational strategies. And this is, again, the evidence for all of these things is very thin. If you look up moral injury emergency medicine in PubMed, you get 840 hits, I believe, and 0 of them are studies that are replicable, that use validated tools, that study interventions in the emergency medicine population. So all of this is extrapolated from the critical care literature, the nursing literature, NICU literature, other strategies during COVID. But there are some things that are thought to be useful, and there is limited evidence. I believe a total of 7 studies in the world's literature on actual RCTs that were done to try to mitigate moral injury. And the 2 main themes of this are leadership and working conditions. So for leadership, one of the things I stress is ensuring alignment between the stated mission and the lived reality. One of the biggest drivers of disappointment in working conditions is like walking in every day and seeing posted on the great big board that we are here to serve and help the underprivileged and do right by our brethren. And then you go in and it's, yeah, but you can't do that CAT scan because they don't have insurance, or you can't get the patient the medicines they need. And that is a big driver of moral distress in physicians, particularly in emergency medicine, because we are the canaries in the coal mine for all of the things that don't work in our other system. Leadership, again, prioritizing staff well-being, making sure that your team knows that you're there for them and to help them be well in their profession, being present for staff, being available. One of the things that was mentioned during COVID was nursing staff who had leaders that were actually present in the department or in the ICU were doing better than people who had leadership that was locked up in their offices or working from home and not actually seeing what was going on the ground. Another strategy as a leader is being transparent in your decision making. There's a lot of literature around leadership styles and what works, and it's difficult to sort of collate because there's a lot of different terms, and what one author calls collaborative leadership, another author calls coaching style, another author calls servant leadership. So it's very difficult to gain any insight from the leadership literature. But one thing that is consistent is being transparent in your decision making and making sure that your staff understands why you're doing what you're doing. And then another important thing that limits staff burnout, not directly studied for moral distress, is providing mentorship and opportunities for growth. So feeling trapped in a job or feeling like you don't have the ability to grow or advance in your field is a very strong marker for burnout in medical professionals, and we believe that this will translate into moral distress. As a leader, these should be the things that you're striving for, but as a worker bee, like these are the things that you should look for in your leadership. If you feel like you're going in and oh, I guess the best way to say it is, if you are a leader, make sure that you are not putting your staff in the position of facing these moral injuries. Like, don't say you're going to do one thing and do another. Don't set policies that change by the time you go in. One of the qualitative studies on moral distress actually talked about multiple emails a day with conflicting policies from, the CDC says this and hospital CMO says that we're going to do what the CDC says. And then 10 minutes later, you get a letter from or an email from infection control that says, no, we're going to do it this way. And then your disaster responder team was like, no, we need to do this. And literally, if you don't read your emails every 10 minutes during your shift, by the time your 12 hours is over, you're doing the wrong thing. And so having a clear, consistent messaging, these are things that you should strive for in your leadership position, but also things that you deserve to expect as a worker bee. And so understanding that this is the situation you want to be in, we believe will be protective. For working conditions, there's so many things that are very, very practical. Staffing ratios and honoring staffing ratios. A PPE was a big stressor during COVID. Lack of access to personal protective equipment was a driver for burnout. And in this case, I think is the moral injury of being the ones on the front line, going in, literally risking our lives with inadequate PPE, does translate more directly than some other situations to burnout and moral injury. Again, an extrapolation, but it seems intuitive that that's part of the same family. A big stressor for staff mentioned in the literature has been visitation policies, taking care of people who are at end of life, who were not able to have their family there, and inconsistency. And, with this charge nurse, they would let somebody in, but the next day they came, there was a different person in charge, there was different staff on, and they weren't able to do literally the same thing they were able to do the day before. So this inconsistency has been very problematic, which gets back to the idea of consistent messaging and equity enforcement and policies. So you have staff who've been redeployed, what training is required around that? What are you going to expect of people when they're working outside of their environment? All of this goes into the potential for harming our healthcare workers, physicians, as well as our nursing staff, techs, paramedics, other people working with us. And efficiency in the practice environment. So do the policies in your institution make it easier or harder to do your job? And things like interdisciplinary ethics rounds have been found to be helpful. Futility policies that are actually able to be invoked and utilized. Provision of futile care is another potential etiology risk factor for moral distress. So having the ability to work through some of these issues. I think one of the most important things about moral distress is that there are some tools to measure it, but the tools that measure it don't necessarily measure the impact or the effect on people. So there are a few validated tools that measure the impact, and none of which have ever been utilized in emergency medicine that I was able to find. So we know that this is out there. There's a lot of opinions and editorials, but actual evidence that things matter is lacking. But one thing I say to everyone who's looking at joining an institution or looking at new jobs is, your institution values the things that it reimburses their leadership for. So if your nursing leadership is going to be given a bonus based on nursing retention, that means it is important to the facility. And that is a way that you can demonstrate as an institution that you value your staff. The institution is sending a very different message if they are perhaps incentivizing their leadership on OR turnaround times or growth of outpatient elective services. So understanding that, how that impacts your day-to-day practice, I think can make a very big difference in alignment between your values and the institution where you're working. But again, that particular bit of wisdom is just my personal opinion after looking at this and thinking about this and figuring out my own career pathway and what I'm going to do. I would love to say there's evidence for that, but As the phrase goes, more research is needed.
Thank you so much, Cindy. Hi there, I'm Vitas. I'm one of the medical education fellows at Stanford. And I just wanted to kind of start to conclude our conversation. And first, I guess, ask from the audience if there were any major takeaways or conclusions or anything that they feel they'd like to add, or any takeaways that they might try and bring back to their own institution regarding moral injury, or anything that they hadn't thought about when it comes to moral injury that maybe they feel more informed now given our discussion today.
One thing I wanted to mention is that the occurrence of a moral injury, as with other types of stress, you don't have to resolve the situation in order to be able to mitigate the effect on yourself. So taking positive actions, whether that is reaching out to a politician regarding a possible legislation that's being debated, working with your hospital on policies that protect patients, all of these things reduce the impact on the individual, even though the situation is still ongoing.
Absolutely. I think that, I don't know, this was a headline from the New York Times, actually shared with me from Dr. Walker, who's on this call. But I feel like this kind of embodies exactly what you're getting on. We've talked about burnout for a while now, but I thought this was an interesting op-ed about kind of, we're not necessarily burned out, we're just demoralized from our health system. How can we think about, from a leadership standpoint and an organizational standpoint, helping to try and mitigate some of this, not only burnout, but moral injury that we're suffering from.
I do think also there's a role for us here to kind of figure out what we can continue to do and what boundaries we need to set. Reading this article and many of the conversations that we have here, it can look like the workforce has this bleak future, and I don't think all of us should quit. Some perhaps should consider that, if you're really to the point that this is really nuts, why are we doing this? But I do think that there are ways for us to create an environment that works for us, right? There are times that I'm being asked to see more patients in the waiting room, and there are days I was I can't, I really cannot. It is so dangerous for me to leave my zone right now to see more patients in the waiting room. And part of that, as what Stephanie was pointing out earlier, is knowing what's within my control and what's beyond my control. And for me, it took me a lot to figure that out. But once I've kind of got a grasp of really honoring my own values, then it's a lot easier to also say, no, I'm not going to break my back and see patients in a waiting room, because if I discharge them and bad things happen, I know that it'll just be me being questioned and not the institution for having this environment that we cannot see all these patients at a timely moment. I see Amanda and Mark, so clearly that pokes something in the audience. This is great. Amanda, go ahead.
I love it. And thank you for sharing that, LA. I think it's just so important as you're saying that. And I think you and I always practice together, even setting boundaries and doing that. And I feel comfortable telling people no, that is something I've practiced for many years. But I think one of the things we can all do, and I hope that people take away from part of this conversation, is also empowering and teaching people that you work with, all of your colleagues, whether it's nursing, doctors, residents, med students, teaching them to speak up for themselves and to say things, because I think that's part of where some of the additional moral injury obviously can come from, of seeing those things, feeling like they can't talk about it. But we have to be the ones to start teaching and changing that culture, that it is okay to sometimes stand up for ourselves or say something's not right about this. We won't be able to change everything in a lot of these scenarios, obviously, with boarding and things like that, we cannot. But some of those situations that you feel, you can start to already get that sensation in the ED in those moments, we can make a difference. And I hope that you have those people around that can start supporting you. If not, message me. I'm always happy to start talking to people, but that's what I think we can do, and what you reminded me, LA, as I listened to you talk about that.
Yeah, and this is also your expertise, right? Like some low-hanging fruits about what else can we do as leaders. You've done a lot of work on gratitude and appreciation. I think part of our work as leaders is to also just acknowledge that these things are real, not to just say like moral injury is not burnout. That's correct. But also just having the space like this to acknowledge like we are experiencing moral injury almost on a daily basis, if not multiple times throughout the day. And these things are real. These things are taking a toll in us. And so we need to also kind of understand our role in it and also understand like what the institution can do for us. Like I'm looking at Dr. Bentley, who's the chief wellness officer. Like I'm sure like she's done a lot of work on addressing these types of work. And yet at the same time, like no, I don't know of any place in the country or the world who's never had any, who doesn't experience moral injury anymore, who doesn't experience burnout, who doesn't experience PTSD. And so we have to embrace part of this as maybe this is the new, now that we're understanding the landscape of medicine, that this is part of our work. And at the same time, what can we do to minimize or prevent things from actually affecting us? Just like your work, Amanda, on leading the Stop the Stigma EM campaign, like honoring people to having that discussion, honoring people to having the space to even have professional help when it gets too much, right? And even for me, like understanding the idea of moral injury, part of that is betrayal of ourselves. And so we have to be able to forgive ourselves and also be kind to ourselves when we go through this, because if we don't, then I'm not saying you can self-compassion your way out of this, but part of it is also to be able to forgive yourself, that there are some things here that we're kind of forced to do, and we are making some decisions that lead to that. I see Mark's hand, and I definitely I'm looking at Susie to get some points here as well.
Well, I guess I just it did connect with me what you had to say. And 2023 is my 45th anniversary working clinical shifts in the emergency department. Most recently was yesterday, 3 to 11, and I'm back on Thursday. It's certainly been really challenging this past 3 years, but two areas in it, maybe kind of bit of a mindfulness type of practice, is that I have certain approaches that really help me put things in perspective. One is I call it the pebble in my shoe. And what I mean by that, if maybe some of you have heard this sort of story, but basically if you were out, hiking in some absolutely gorgeous, scenario somewhere in the mountains, it was beautiful, and the pebble got in your shoe and it started to hurt, and you would stop and actually take your shoe off and discard the pebble, put your shoe back on, and continue to enjoy the beautiful scene and the environment and everything that was happening. But in our work, we tend to not take the pebble out of our shoe and let it just continue to hurt, and sometimes even then carry on conversations about the pebble, which adds more mass and reality to it, when in fact it's just a pebble in your shoe, and it's not the big picture of your purpose or your mission at work or in life for that matter. And then I connect that up to the starfish story, which you probably many of you probably heard. And the person who's on the beach with hundreds of starfish that have washed up and the tide has gone out, and this child is picking up one and throwing it back in the ocean, and some adult comes along and says, "What are you doing there?" And the person says, "Well, I'm putting the starfish back." And he says, "Well, what difference is that going to make? There's hundreds of them here. What difference can that make?" And the person says, "Well, it's making a very big difference for this starfish that I'm throwing back in the ocean." And it's kind of like there's always a starfish somewhere where I can make a difference. And sometimes the difference is just having a conversation with somebody. It's not always the big case in the chest tube and this and that. It's just some loving moment of kindness with a patient or a staff member. And I just keep using that to true up to my mission and my purpose, and I speak it because I think the more we speak it, the more it helps shape our experience. And some of what we seek and experience, it doesn't exist unless it's languaged and brought to life in language. It's not an object. The feeling of fulfillment, the feeling of love, the feeling of purpose, none of those things are objects in the world with mass, weight, and they're not going to be there tomorrow just because you spoke them last week. And so I mindfully would discipline myself to speak a language that gives me something to live into.
Dr. Contra, did I see your hand raised as well?
Yes, thanks. Yeah, so I participate in a program at my institution, the Scholars of Wellness. And to Mark's point, one of the director's main things is to focus on the pebble in your shoe. That we may want to solve the biggest well-being problem, but we can only do it in a small way, and look at the drivers of this as the pebble in the shoe, and what little thing can you control and have success at, and then build on that success with each little win that you have. And I think that's a really a great way to look at things, and to try to mitigate some of these issues that lead to moral injury, which honestly are out of our control. So find that little pebble in your shoe that is under your control, and work at that.
Amanda, I really like what you said about kind of taking it upon ourselves to kind of make, and I guess Dr. Konchak alludes to this too, taking it upon ourselves to make those little changes that we are in control of. I remember in training, I trained in an area that had a lot of pressures on the healthcare system, and there were, hallway beds, and there was areas of the ED without very much privacy that sometimes, unfortunately, for better or for worse, drunk patients and psychiatric patients would be in. I remember having to interview patients that were talking about, something like sexual trauma, or mother who just lost the son, and these tragic things. And then, just a curtain away, or not even a curtain away, there might be some other patient who's almost chastising that patient when we're doing a history, and there's certainly no privacy, and it's just not right. And I remember feeling so conflicted and feeling like, is this what I signed up for? This doesn't feel right, or anything that I was taught in medical school. And I didn't really have, as an early resident, kind of the courage to kind of speak up too much about it until I had an attending speak up for me. And now being in that attending role, I kind of remember that, because it wasn't until, attending was like, well, this is not how we're going to do it on shift today, that I kind of felt empowered, as a resident, and then a senior resident, and now as attending, to do that same and model that behavior and say, this isn't an appropriate. I don't care how strained we are as a healthcare system. Like, I'm not going to put this patient through that. And I don't think that this is morally appropriate. But it wasn't until I kind of saw that from another attending that I really kind of took it upon myself to do that. So, well, thank you everybody for engaging
I
in
see Dr. Bentley's hand as well.
That's okay. We were so close to wrapping up. This was just phenomenal. And I loved all of it. And building on much of what was said, and actually what you had just said too, I think role modeling can't be, emphasized enough. We're in such a unique position, and not just for the residents and the junior faculty, but, for the nurses. And I often find myself saying, like, I'm giving you permission to talk to me about how much this sucks. And even though we can't fix it, just normalizing the dialogue, much like this entire presentation around the reality right now. I thought at first, and people have said to me, but doesn't that just bring everybody down? But I really think it actually brings everybody together in a really authentic way that doesn't exploit people. And the reason I say that is because something I'm struggling with, and I'm curious what others think, and it was brought up before about, mission matching reality, is, we even during COVID had this Elmhurst Strong chant. And it was really, really bad. And it was really beautiful, and all the gear, all the swag. But now, COVID, we're moving ahead. And I find now, being in the C-suite, lots of people saying, Elmhurst Strong, when we're talking about problems and this amazing resolve, and people stay because they love the patients. And I find myself reluctantly, but now boldly, kind of raising my hand to say, it's a slippery slope with exploiting people. The attendings that have been here for 40 years stay for the love of the patients, but that doesn't mean that we don't need to fix the whole system. And I think it's really made some people pause, because we all went into EM, we're all a little, we have very high ideals and we're also kind of along for the wild adventure, but it doesn't mean we signed up for any of this. And I think sometimes we have to remind administration that we're here because we love it. We love the hospital. We love the work, but that doesn't mean, you know, that we deserve any less around these conversations. Because I really do think we're hitting that point now where it's like exploiting physicians and nurses and all the people that do keep showing up. So that was just something that kind of stuck with me. And then I just had to add, just for everybody on a positive note, to the military comment. I am not military, but we had a 4-star general say to a small group of us during COVID, they had come and really helped out in Queens at the start, that what we were up against during the first surge was actually far worse than the combat that he had been, you know, under fire. And he gave all these very dramatic examples. And he said, this has actually been far more challenging, both physically because it never ended, but also just the emotion and the moral injury. And I feel like he extended that term to many that hadn't heard it. And that one story gets repeated in a way I don't think anything has been as powerful really for our team in the ED, because, you know, that's like a real authority telling you that what you think is so big and so scary and so heavy, you know, actually does compare to combat in some way. So I admire all of you. I love working with many of you, and there's so much room to improve and partner, and talks like this just give me so much hope and reignited passion. So thanks.
Thank you so much, Dr. Bentley. We're kind of running out of time here, so I'll quickly wrap up, but I wanted to invite everybody to the Wellness Committee Futures events. We meet the second Thursday of every month at 1 p.m. Pacific Standard Time, and everyone is invited. We also have an upcoming webinar in April, and it'll be another lunchtime webinar, I believe, at 1 p.m. Central Time. And that will be focused on beyond burnout, focusing on your personal and professional fulfillment. And then also for those of you who'll be attending SAEM in Austin, Texas this year, we have several different presentations being led by members of the SAEM Wellness Committee. So I wanted to put these on your radar. Closer to the conference time, they'll also be marked as Wellness Committee talks. So take a look at that on the schedule, and you'll be able to kind of follow us throughout the conference. So thank you so much, everybody, for your participation. We're kind of running up to the time limit here. So
well, I'm on time, so that's people don't feel moral injury
Yeah.
to go to another meeting versus staying here. So thank you again, everybody. I really appreciate you. See you on Thursday for a meeting, and hopefully in April to talk about professional fulfillment. Thanks, everybody.
Thank you. Thanks everyone for participating.
Yeah.
It's meant to be a group effort, and audience participation helped a lot.
Love it. Bye, team.